Hi there! Thanks for joining me on this video where we will shift our focus to more physiological aspects of the heart. So let's jump right to it and have a look of the basic heart rhythm. You might remember from our study of nervous system the concept of action potential. I will add a link to the video about it to the end of this one in case you need to review this concept. But in this diagram, we will be looking at the events in a typical cardiac pacemaker cell. And we will see that there are some similarities, but also quite obvious differences in the appearance of membrane potential in a cardiac wall cell. So let's study this. And before we do, I want to mention that although the heart depolarizes and contracts without stimulation from the nervous system, the rhythm can be altered by the autonomic nervous system. And there are two important elements that drive the coordinated heartbeat. Let's look at those. First, we had gap junctions that facilitated quick and efficient progression of messages and chemicals and so on from one cell to another. And secondly, we have a network of cells that are not involved in contracting themselves, but rather play a role in initiating and conducting the impulses that coordinate depolarization and contraction of the heart. And these action potentials that we will be looking at, those are initiated by pacemaker cells. We will focus on those first. And unlike the nerve cells in the nervous system, which we studied in our last course, that had a resting potential of negative 70 millivolts, the cardiac pacemaker cells have an unstable resting membrane potential. We can see that here. This pacemaker potential that you see here, please note that it is never a flat line. Instead, it is slowly depolarizing, and this is due to two processes: sodium channels opening and potassium channels closing. Then, we get to the actual action potential. This starts with depolarization, which is highlighted here, and this begins when the pacemaker potential reaches a threshold. And this is due to calcium influx into the cell through the calcium channels. Final stage of our action potential is the repolarization. This is due to calcium channels becoming inactive and potassium channels opening. As a result, there is a potassium ion efflux, which brings the membrane potential back to its most negative voltage. So, there you have it, our basic heart rhythm and how the events generate it. Similar to the action potential, but different. And these cardiac pacemaker cells pass impulses across the heart, progress in about approximately 200 to 400 milliseconds. In contrast, the nerve cell's action potential lasted for 2 to 5 milliseconds. So cardiac pacemaker cell potentials are much slower. Let's look at the sequence of excitation through the heart. So we will move from smaller cellular level to look at this in a bigger scale, a series of events. So, the sinoatrial node known as SA node is the pacemaker of the heart. It is located in the right atrial wall, and it depolarizes faster than the rest of the myocardium, generating something known as sinus rhythm. This is about 75 impulses per minute. And then these impulses then start to spread throughout the atria to the atrioventricular node. This is also known as AV node. This AV node is located at the internal septum and provides a delay of approximately 0.1 seconds before the impulse is propagated further. This is important because this small delay allows the atria to contract first, and only after that the ventricles start contracting. So we are establishing a rhythm to the cardiac contraction process. Now, the impulse progresses down the AV bundle, which is also known as the bundle of His. This is located in the interventricular septum wall and provides the only electrical connection between atria and ventricles. Now, we get to the Bundle branches on both right and left side of the heart. These carry the impulses towards the apex of the heart in the septal wall. And finally, we have Purkinje fibres, sometimes also known as subencocardial conducting network. They complete the pathways, taking the impulse up the ventricular walls, being somewhat more elaborate on the left side of the heart. The impulse here is immediately followed by a contraction that spreads from the apex towards the atria. And if we think of the clinical relevance of this, there are two cases that I especially want to highlight as they relate to the defects in the conduction systems. Firstly, arrhythmias, which are of course irregular heart rhythms. And also fibrillation, where we have fast irregular contractions. See on this first image of ECG a normal cardiac rhythm, and on this second image a case with fibrillation. This makes the heart useless for pumping blood and the circulation ceases, resulting in a potential brain death and so on. So what can you do in this later situation? Of course, as I'm sure you noticed, we would use an automated external defibrillator, defib. This interrupts the chaotic twitching with an aim to give a clean start for the regular and normal contractions. One more clinical case that I want to talk about is when we do need to implant a pacemaker into an individual. This is when AV node is defective, either by resulting in too little or no impulses, so the ventricle beat becomes uncoordinated. What a pacemaker does in this case is that it recouples the atria and ventricles. Next, we should talk about where the heart rate is regulated from. Well, this is done by autonomic nervous system from the medulla oblongata. Remember this from our revision of the structures of the brain in BIO201? If not, I have added a link for this as well to the end of this video. There we will find cardiac centers from where the signal runs down the spinal cord and nerves to the SA and AV nodes. This is for speeding up the heart rate. And to slow down heart rate, we rely on the vagus nerve. This was the wandering nerve that we also talked about. It calms down and slows. Earlier, we revised the electrical events in the basic cardiac rhythm in the conducting cells. Now we should look that in cardiac muscle cells. Let's see what we can note here. First, depolarization occurs as a result of sodium influx into the cell. This happens through fast voltage gated sodium channels. And here we actually see many sodium channels opening through a positive feedback mechanism. So the membrane potential gets reversed towards positive. This phase ends in channel inactivation. Next, plateau phase is a result of calcium influx into the cells. This happens through slow calcium channels. This keeps the cell depolarized because most potassium channels are closed. And finally, repolarization. This is due to calcium channels inactivating and potassium channels opening. This allows potassium efflux, which brings the membrane potential back to its resting voltage. So that's it for the action potential of cardiac cells. Remember that cardiac action potentials were longer than those in the nerve cells. This is important because the delay allows efficient ejection of the blood. We also have longer refractory period. This was the recovery period, and it is to prevent uncoordinated contractions. And next, I would like us to look at electrocardiography. This is often abbreviated either as ECG or EKG. And what we do with this method is that we measure the electrical currents generated by the heart through 12 LEDs that have been placed across patients' body, typically mostly on the chest. What I want to highlight regarding this method is that it shows a summation of all action potentials rather than tracing a single one, as we saw earlier on this video. So what we will do is that we will take a typical ECG trace and analyze different components of it. Why don't we get started? The first bump that I want to introduce here is the P wave. It results from the depolarization of the SA node and atria. This is soon followed by a series of events called jointly as QRS complex. During these events in the heart, there is repolarization of the ventricles and atrial repolarization. And finally, we have a T wave, which refers to the ventricle repolarizing. You might wonder, why is this useful for us? Well, by knowing what and where we are expecting to see and measuring the distances between these events, we can gain significant important information about possible conduction issues within the heart. Analyzing ECGs is a useful skill which I encourage you to look into. So, what we are going to do next is to look at the mechanical events of the heart. And to understand these, we are going to need to look at some important terminology to ensure that we are clear of what we are talking about when we talk of different events taking place. So let's get started with that first. Systole is the period during which the heart contracts. Usually during this time, blood leaves the structure in question. Diastole is the period during which the heart is relaxed. Typically, during this time, the structure in question is filling up with blood. And finally, we have a term cardiac cycle. We refer to one complete heartbeat and how blood flows through the heart during it. So let's look through 3 phases of a cardiac cycle, following the left side, starting with a total relaxation. During ventricular filling, we are observing the mid to late diastole. And during this time, the pressure is low and about 80% of the blood passively flows from atria through open AV valves to ventricles. Note that during this time, the semilunar valves would be closed. Once atria depolarizes, atrial systole, which we see as P wave, is triggered. Atria contracts and push the remaining 20% of blood into the ventricle. This depolarization will now spread to the ventricles, seen as a QRS wave, and the ventricles begin systole. And during ventricular systole, now the atria relax and ventricles begin to contract. We see that the rising pressure in the ventricle causes the AV valve to close. And first we see that all valves are closed. This is called isovolumetric contraction phase. It is followed by the ejection phase, during which the ventricular pressure has now exceeded the pressure in large arteries, pulmonary trunk, and aorta, forcing the semilunar valves to open. And the final stage is isovolumetric relaxation. This is the early diastole. Here we see that the ventricle has repolarized, seen as T wave, and now ventricles are relaxed and atria are relaxed and filling. As a result of the backflow in aorta and pulmonary trunk, the semilunar valves close. Ventricles become totally closed chambers. When atrial pressure exceeds the ventricular pressure, AV valves will open again, and the cycle begins once again over. So, those are our 3 stages. I think they nicely summarize a lot of events involved. The next thing that I want to discuss, just briefly, is the heart sounds that we can hear. These are important in clinical practice and a very simple yet effective method. These 2 sounds, often referred as lub and dub, result from the heart valves closing and can be heard with a stethoscope. Let's look at what causes each in a little more detail. Well, the first lub sound is caused by the atrioventricular valves closing, and the second dub sound by the semilunar valves closing. Of course, the delay in between these two is the period of heart relaxation. You can listen to these sounds from different locations in order to gain more detailed information on different valves and how they function. And the clinical relevance of these is the abnormal heart sounds heard when the blood hits the obstructions. These are, of course, heart murmurs. They usually indicated a valve problem, either failing to close, in which case there is a backflow heard, or failing to open, in which case the flow is heard as being restricted. Now, let's finish by considering just a little bit about the volumes of blood pumped by the heart. How much blood do you think that each ventricle pumps out in a minute in a typical person? Well, the correct answer would be about 5.25 liters. This is about 1.37 fluid gallons for those of you who prefer imperial units. So, how do we come up with this number? Well, cardiac output, which is what we are essentially looking for, is the sum of the heart rate and stroke volume. And we know that typical heart rate is about 75 beats per minute. And volume of one ventricle per one beat is about 70 milliliters. So the next question that I have is, do we always pump as much blood? And the answer is, of course, no. The amount of blood pumped can be changed. While at rest we are at about 5.25 liters, as we saw earlier on, the maximum would be somewhere between 20 and 25 liters per minute. Some athletes can reach even 35 liters per minute. But for most of us, this is about 4 to 5 times more than normal cardiac output, which to me is quite a jump. So what do we do to change this? We can change heart rate by activating the sympathetic or parasympathetic nervous system, through hormones or ion concentrations of cells, and of course other factors play a role too, like age, sex, exercise level, body temperature, and so on. Or we can adjust the stroke volume by altering how much the heart stretches, adjusting strength of contractions, or how hard ventricles must contract to excrete the blood. So these are some of the mechanisms how cardiac output is altered. And this will conclude this video, which focused a little more on the physiological aspects of the heart. Thank you for joining me on these 2 long videos.